welcome. I will start presenting myself. So I'm Maria Piggin. I work for the ERN-EuroBloodNet, so the European Reference Network for Rare Hematological Disease. And I'm very honored to welcome all of you at this special webinar roundtable that gathers key expert physicians and very passionate and dedicated patients representatives. So today we are going to talk about risk and course of COVID-19 in aplastic anemia and PNH patients, including vaccination strategy. And this is a lecture targeting patients and their family. And as I said before, this program really aims to provide cutting-edge knowledge for patients and their family. And we will have a health professional expert on this field. And the program is very patient-centric because it has been shaped with two patients association and patients representatives, so PNH Support. That is an association focused on PNH and is represented by Maria Piggin, that is with us, and an association called Lichterzellen, focused on aplastic anemia and PNH, and today is represented by Pascale Olivia Burmester. We will have, as said, a round table, but before the round table where you can address your question, comment, participate to debate, there will be two presentations. So I will introduce to you the round table. So we will have first Professor Corrado Girmenia from Hospital Policlinico Umberto in Rome. Then we will have Professor Austin Kulasekararaj from the King's College in London. And in the round table, we will have Régis Pelfo de la Tour from APHP Hospital Saint-Louis in Paris, Antonio Risitano from Federico II in Naples, and Carlo Dufour from Gaslini in Genoa. All the moderation of the question and the answer will be done by Maria Piggin and Pascale Burmester that I've already introduced to you. And I also would like to explain that we have already pre-collected the question via the Patients Association through a survey. So we have already got your input about what are the key concepts you will ask the expert to tackle today and to speak about. So those will be taken into consideration, but of course, feel free to intervene, ask questions, raise comments, share your thoughts and opinion. Before starting, I'm sorry, I'm speaking a lot, some few house rules. So as you can see, this session is recorded. So if you don't feel at your ease, you can put your camera off or changing your name. And also your microphone will be muting in the first part, so during the presentation, but at the end, you will have the possibility both to write your comment or question in the chat, or also to raise your hand and take the floor and speak. So I'm very happy now to pass the floor to our two first speakers. So first, Professor Girmenia, and then Professor Kulasekararaj, and then we will have the round table. Thank you very much.
Can I just ask something? It's Bev Arnold. How do I get my photo up?
Sorry, could you repeat?
I can't get my photo up. Also, you can't see me, can you?
No, we cannot see you. Maybe it's because you're calling from a phone?
No, from my iPad. And normally my photo comes up, but
I don't know.
Not at the moment. I don't know how to do it, but don't worry. If okay. I'll just listen and and try and take part.
Great.
Okay, good afternoon to all. Thank you, Mariangela, for the introduction. I'm Corrado Girmenia. I am an hematologist and my field of clinical activity and clinical research regards also infectious complications in hematological patients. And I'm very happy to collaborate with several hematologists, in particular in Italy, on the several infectious problems in PNH and aplastic anemia patients. And as you can understand, COVID-19 represented a challenging problem for the hematologists, for the patients with hematological diseases, because there is a very wide range of diversity in the impact of this infection in the various hematological diseases. So I will be pleased to share with you the literature data and some considerations regarding the management of COVID-19 in a patient with aplastic anemia and in patient with PNH. And first of all, what are the key issues in the most important key issues in the management of COVID-19 in these two groups of patients? The first question, the issue is, the question is, what is the risk for PNH and aplastic anemia patients of getting COVID-19? And what is the risk of to develop a severe infection compared to the general population? Then a second problem is related to the vaccinations. First of all, the safety of this vaccination. A particularly important problem is the risk of trigger of hemolysis triggered caused by the vaccination itself. And not less important, some data regarding the effectiveness of vaccination in these patients, but regarding these issues, Austin will give you important details. The first question is the risk. The question is, do PNH patients are at increased risk to develop infections? But this is an uncertain problem, an uncertain issue for several categories of patients. We don't know if some patients are at increased risk to get infection. And we have some data, at least from two large studies. The first one from Italy, the first name is Vilma Barcellini, and the second study from the Leeds group. In this study, generally with the data collected during the first two waves of the pandemic, we can see that the cumulative incidence of infection in the first study out of 156 patients was 2.5. And this incidence of infection was comparable, was not different from that observed in general population. As you can see, out of 156 patients considered, 4 cases of infection were documented, generally during the second wave at the end of 2020. And it refers the diffusion, the epidemiological findings of the infection. So also the study from the Leeds group, which considered more than 200 patients, the rate of infection was less than 2%. So in both studies seem to show that the risk to get infection is not different from that of the general population. comparable data in studies focused on patients with severe aplastic anemia, the first one from the States and the second one from the Great Britain. In both studies, only few cases of severe SARS-CoV-2 infection in patients with severe aplastic anemia were documented. We have not the real data regarding the cumulative incidence, but presumably this risk to get infection reflects the risk to get infection of the general population. These studies show also the second important issues regarding to the risk of a severe infection. What is the outcome of COVID-19 in these two populations, considering that both are considered a population with reduced immune defenses due to several causes. But in the data from this study seems to show that the outcome of and the presentation of COVID-19 is not different from that of the general population with the same demographic characteristics and comorbidities. We have to consider that when we compare two populations in related regarding the outcome of COVID-19, we have to consider the balance of the age, that is really important, and the other comorbidities such as diabetes, cardiovascular diseases, and other comorbidities that may impact on the outcome. And regarding the available literature data in PNH patients, out of 12 cases reported in literature from these two large series and from other case report, there was only one case of that in a patient with severe diabetes. So we can conclude that in PNH, SARS-CoV-2 infection does not seem to have a better outcome, a worse outcome compared to the general population. Also, for the few cases of infection reported in patients with severe aplastic anemia, regardless of the treatment for the underlying disease, the outcome does not seem so bad compared to the general population. And the second important issue is the safety of the vaccination, particularly regarding the risk to cause an hemolysis after the vaccination. The risk to develop a breakthrough hemolysis, an hemolysis in PNH patients after vaccination is a well-known phenomenon also with other vaccines. With the difference different degrees, any vaccine can cause an inflammation. This is a common reaction to the vaccine, and so an inflammation may cause represent the trigger for the phenomena that lead to the hemolysis in PNH patients. So in the large series of patients from the from 8 Italian centers, overall 87 patients with PNH, there were observed 12, about 13% of cases of hemolytic exacerbations, but only in 2 cases, supporting therapy, and in particular transfusion and hydration, was required, and only few cases, in only few cases was required hospitalization. So we can conclude that vaccination may cause hemolysis in this group of patients, generally self-limiting hemolysis, but this is a common phenomenon observed after any type of vaccination. I have to underline the fact that also the SARS-CoV-2 infection, COVID-19, which is characterized by an hyperinflammation phenomenon, we know that may cause hemolysis in PNH patients. So this is a side effect not unexpected. No other side effects were observed in patients with PNH, or at least different from the other population. Regarding patients with the severe aplastic anemia, we have only few experiences. Here is reported an experience in only 16 patients. And in this experience, a good response to vaccination was observed without relevant side effects. So I can conclude with some considerations regarding the management of COVID-19 in PNH and aplastic anemia patient that be the trigger for a discussion. The first one, we can conclude that according to the available data, the risk of PNH and the aplastic anemia patient getting COVID-19 is comparable to that of the general population. The data I present to you regards generally the first two waves when the alpha and delta strain of SARS-CoV-2 represented the more diffuse strains. We have no data from the literature regarding the current strains that are now causing another wave of infection, but our personal experience, impression is that the risk to get the infection is not different from that of the general population for the Omicron strains. With regard to the risk to develop a severe infection with the worst outcome, we can conclude according to the data that the outcome is comparable to that of the other population, and does not seem that also patients with aplastic anemia under immunosuppression, or a patient with PNH under complement inhibitor treatment at higher risk of severe infection. Regarding to efficacy, Austin will detail you more data, but I can anticipate that the vaccination is effective after a complete vaccination course. And although vaccine-induced hemolysis has been observed in several PNH patients, in most of cases, these phenomena do not require therapy, supportive therapy, or hospitalization. But I repeat, this is not an unexpected phenomenon. For this reason, the experts continue to recommend the vaccination against SARS-CoV-2 in PNH and aplastic anemia patients, despite these problems. And some data seem to show that the risk of hemolysis in PNH patients is lower when the vaccine is administered closer to the administration of the complement inhibitors. So we can suggest to administer this vaccine, but any type of vaccine, during the first week after eculizumab and during the first 2 weeks after ravulizumab. Also for this conclusion, I wait a discussion with the expert and the patients, and I'm pleased to leave the presentation to the presentation of Austin.
Thanks, Corrado. I'm just going to try to present my screen. Hope you can see, because I've got two screens and it gets confusing. Can you see my slides?
Yes.
Yes.
Perfectly.
Okay. And it's on slideshow. Yeah.
Not yet.
Okay. Is it at least moving to the next slide?
Yes, it's scrolling, but we cannot see it in presentation.
Okay, sorry, Angela.
Oh. Well. Did you try clicking on the images on the right at the bottom?
Yeah.
Yeah, it does.
So it's not moving, is it?
Yes, it's moving, but
not on slideshow.
Yes, exactly.
Okay. Still not, is it? Oh, I think what I will do. I'll stop share and then try to reshare.
Yeah,
apologies.
usually it works. If not, it's not a problem. I mean, you can make it bigger manually as option B.
Okay, now I'll
try.
Now I'll try this. Maybe.
Did you try to share not the presentation but your desktop screen?
Yeah. Is it any better, Maria Angela?
No, it's as it was before.
Okay, that's fine. Let me share my desktop screen.
Yeah, it's easier because sometimes it's big size, PowerPoint, the Zoom, it's very slow. So I think sharing your screen desktop, it will be the best option.
Okay.
Yes, it works.
Okay. Thanks.
Thank you too.
You can see the first slide or second content.
The content of the session.
Okay, I'll just see whether I can move. Okay, great. Okay. Apologies all, technology.
No, don't worry, it's perfect.
Okay, I'll try to keep it very short, 5 minutes, so that we can have active discussion. And please don't put off by the slides. It's quite medicalized, but I'll try to talk around it and keep it as simple as possible. So my name is Austin Kulasekararaj. I'm a consultant at King's College, and I lead one of the PNH centers. And it's great to have this session with patients as well. So I think we talked quite a lot about COVID and its impact on aplastic anemia and PNH through Dr. Corrado's talk. What I'll try to do is impact of vaccination on, rather than impact, I'll look at the effectiveness of vaccination on aplastic anemia and PNH, whether patients are on treatment either with cyclosporin, ATG, eculizumab, ravulizumab, and other treatments as well. Unfortunately, we do not have, as a medical community, have data on effectiveness of the third dose, booster, fourth dose, and the autumn booster as well, which has at least been started in UK, i.e. patients will get a fifth vaccination. Again, there is not much data yet on effectiveness of antiviral medications for aplastic anemia and PNH patients, i.e. antibody treatment or antivirals, but that will come, I think. So I think it's quite timely because this is a fantastic data which was just published in Lancet Hematology last week, and it's quite timely because this is probably one of the largest series of data which is looking at vaccination responses in both patients with aplastic anemia and PNH. So I don't have any issues with presenting this data, predominantly or mainly done by the Leeds PNH Center in collaboration with funding from Aplastic Anemia Trust and also Blood Cancer UK. So this looked at a very large series of patients over the last 16 to 18 months. So this is, again, data which was, some of the data was presented in our national meeting. So I've taken some of the data and some of the data which I'll go through it. So it's a real world data looking at patients both with aplastic anemia and PNH done through the PNH UK Leeds Center, and any patient with PNH or aplastic anemia were eligible. So these were patients on treatment, not on treatment, on cyclosporin, not on cyclosporin, previously had ATG, never had ATG, PNH patients who had anti-complement therapy, i.e. eculizumab and ravulizumab. So the only exclusion were patients who had a stem cell transplantation or had other conditions like rheumatoid arthritis, and they were on other immunosuppressive therapy. So I don't want you to read the whole table, but essentially, as I said, compared to healthy volunteers, again, there were 171 patients. And the fantastic thing about this study was it had aplastic anemia patients, patients who had aplastic anemia, and also PNH. We call it as aplastic PNH overlap, and some of the patients would have heard. Some of the patients who had classical PNH as well, and these patients were included in the study. And some patients had vaccination with the Pfizer vaccine. Some had vaccination with the Oxford vaccination, as in Oxford vaccine as shown here. I don't think so there were any patients who had Moderna vaccination. So this is looking predominantly at the Pfizer and the Oxford Pfizer and the Oxford AstraZeneca vaccination. So this is again looking at samples done after first vaccine, after second vaccine, 6 months, and then post-secondary. But the only data I'm going to present, which was published and by Dr. Alexander Pike is looking at responses after first vaccine and second vaccine. And you might have heard different types of responses. One of the classical ones we always talk about is antibody, which is a particular type of response which your immune cells produce. But there are various other antibody, various other T cells in one's body which might respond in a different way as well. So that's just giving you a caveat as well. So this is looking after first vaccine in healthy volunteers and patient. So what it showed was, so this means that you had a response above this line means you had a presence of an antibody. So that showed that in patients who had one vaccine, it was shown that compared to healthy volunteers, the response was quite low. And if you look at those three groups of patients, i.e. classic PNH, aplastic anemia PNH, and also isolated aplastic anemia, that difference was still there, i.e. after first vaccine, patients respond poorly compared to healthy volunteers. And this is shown in a different way here as well. But reassuringly and thankfully, when you look at post-second vaccine compared to healthy volunteers and patients, there was no difference. Yeah. So this is statistically, there was no difference, i.e. patients responded irrespective of whether they had PNH or aplastic anemia PNH or aplastic anemia, and they had a good response post-second vaccination. So the take home here is with 2 doses of vaccination, patients with these conditions seem to be as protected as a healthy volunteer who does not have PNH or aplastic anemia. But what other factors could we see? So historically, it's been shown that even in healthy volunteers, as you get older, the responses seems to be lower. And one of the good things which this study showed was it doesn't seem to be the case when you have PNH or aplastic anemia or overlap syndromes. Age did not come into the equation in antibody responses. So irrespective of the age of these patients, they had a response which was sometimes even better than a healthy volunteer. So that's sort of a slightly reassuring aspect in this study. Secondly, what happened if a patient with aplastic anemia or even PNH were on cyclosporin. And again, reassuringly, it shows that cyclosporin did not impact on one's ability to respond to antibody production. So it will be interesting to see what the T cell responses were for these patients. And lastly, in this study, they've also looked at the type of vaccine. So here, this is the Oxford vaccine, and this is the Pfizer vaccine. After first vaccination, there seemed to be no difference, but even after the second vaccination, there seems to be slightly a better benefit with the Pfizer vaccination than the Oxford vaccination. So, but again, you need to take this with a pinch of salt, because antibody responses, as I told you before, is only one type of response, because these patients could have a better T cell response, and thereby maybe the vaccines might be equated. So this was one of the conclusions, which was again presented. So showing that you show a reduced response after one vaccination, but if you have two vaccination, it does not seem to be impacting, i.e. patients who have two vaccines seems to have a very good response, even if they are on cyclosporin, even if they are on eculizumab, ravulizumab, irrespective of the age as well. So essentially to show that the two vaccinations are mandatory or quite important in patients with PNH AA. One, it seems to have the same effect as healthy volunteers. And they also looked at adverse events, and there doesn't seem to be more adverse events in this group of patients compared to healthy volunteers. But it is important that we need to continue to look at this data. So just a pitch for this EBMT study, where Maria Griffin, who's the PI of this study, who leads the lead center, is looking at the vaccination effect in AA PNH patient. And she has, through all the European sites and UK sites, have collected a large series of patients to see what are the immediate and long-term effects. So just a caveat to say, this is will be a large study. There have been loads and loads of case reports and smaller studies of looking at vaccinations, side effects, and then efficacy. But hopefully with this data, I've been able to show, yes, vaccination seems to have a protective effect if given 2 doses in patients with AA and PNH. Irrespective of the treatment, side effects have been seen, but not something which has been deleterious over a period of time. So I think with that, I will stop, and maybe we could move on to the next session, and happy to discuss. But finally, a big thanks to the people who helped in putting this previous data, mainly Dr. Pike and the lead center, who collected this large series of data over the last 12 to 18 months and able to put it out to the world to say that the efficacy of the vaccination in this group seems to be quite good as healthy volunteers. So I think with that, I will stop the screen sharing as well, and happy to discuss further.
Maybe I will proceed with introducing some of the questions that the participants sent in. Thanks to all of you for sending those questions in, and a big thank you for presenting this very interesting and informative information. Some of the questions that the participants sent in have already been answered in the presentation, but some of them are still left over, and so I will proceed with those. One actually, I think, Austin, you actually covered this. Will I need a 4th vaccination? I will cover the questions on the vaccination first. So one is, will I need a 4th vaccination? Could you please advise on COVID-19 vaccination strategies for AA and PNH patients general, which you already did, but basically this is concrete on the 4th vaccination.
Yeah, I think as far as the current data is available, if you look at healthy volunteer data in the context of 3rd vaccination, so there have been quite a lot of studies published recently, predominantly coming from Israel and Qatar, where they've looked at healthcare workers when they got their third vaccination, or they called it booster vaccination. So the one thing which has been shown in those group of not patients, healthy volunteers and healthcare workers, is that the protection given by the vaccination, the second vaccination, seems to go down over a period of time. I think it was around 200 days of median around that in that data. But people who had boosted, i.e. the third dose of vaccine, seems to maintain their vaccination levels or the antibody levels at a protective level, so potentially prevented. So if we use the same data with patients, then it's likely that the amount of antibody levels in the protection will go down over a period of time, and having boosters or third doses and fourth doses will be helpful to keep the protective levels going for a period of time. But the only caveat, Pascale, is unfortunately we don't have that data yet for patients with aplastic anemia and PNH. But if it follows the general trend, I would generally advise that patients should proceed with the recommendations in their individual country, be it a booster dose, be it a fourth dose, or be it an autumn or a spring booster, like the other patients in the clinically extremely vulnerable group.
Thank you. Then one question was, is there a vaccine that should be preferred? To any of you, please.
I don't know, I can quickly take it, and then Dr. Corrado and Antonio Regis or Carlo might want to pitch in. I don't think so, which is why I showed you that data of antibody responses. And this has been shown when we did the study on patients with myelodysplastic syndrome and also other cancer patients. Generally, it seems to be that the antibody responses are better with the Pfizer-BioNTech vaccination, but the AstraZeneca-Oxford vaccination seems to have a better T-cell response. So when you put it both together, it seems to be that the cumulative effect of each individual vaccination might be similar between the vaccines. And unfortunately, I don't know much of the data of other vaccines like Moderna and J&J. So the most of the times it is around the Pfizer and the AstraZeneca vaccines.
Yeah, I have the exact same feedback than Austin on that matter. I mean, vaccines are not really matters. The most important is to be vaccinated. We did not have access so long in France to the AstraZeneca, of course, and we are more using Moderna and Pfizer. But again, the vaccination is more important than the vaccine itself. Just something more from what was the first discussion, because something for patients, it's not always obvious. A booster is important, but an infection is like a booster. So in other words, if you got infected while vaccinated, it's like a booster. So most of the time, of course, the disease is far less severe because you're vaccinated. But then if you need another dose or a booster, you have to do it 6 months after the infection. So sometimes it's not so easy to manage boosters every 6 months. But if you got COVID, then it's like a booster.
Thank you. And somebody asked, what does titer or titer mean? And does it say anything about my protection?
I don't know. Simplistically, I think it all depends upon. So titer means the level of antibody or the level of protection against COVID derived either through infection or through vaccination. And there should be a particular level above which it's usually protective and below which it is not protective. I think there is a helicopter coming over my head, so I'll let others answer.
Anybody else who wants to pitch in?
I think that the question from a patient is not only if what is the cutoff of protection, but if the detection of antibodies is useful to decide for the booster or to decide for the risk or to show the risk of infection. But according to the literature, there is no correlation between the level of antibodies and the risk to develop infection. So it should not be used to decide if to be vaccinated or not to be vaccinated. According to the guidelines, we know that after some months, the protection decreases, and it is not appropriate to decide for a booster according to the level of antibodies. It could be misleading in some cases, and usually it could be a self-made medical decision, and it is not appropriate in my opinion. I don't know what the other colleagues, what is their consideration.
Well, honestly, on that matter, I'm very pragmatic. I think that there is no data in the literature to support if there is a role of the titer or not. There is some data that say that you need boosters to be protected at least every 6 months. So I would not go further. That's what we have. And in the end, yes, sometimes we are looking for titers to see if people are responding, because then for immunosuppressed patients that might involve other protection like antibodies injection. So if it's yes or no, but then if you have a titer, we are not dealing with it to predict if the patient is more protected or not.
Okay, thank you very much. Then I have some questions on the vaccines from patients with aplastic anemia. One is, does the vaccination can cause my aplastic or aplastic anemia or have an impact on my blood counts? So basically, this is a question of, can a vaccination cause aplastic anemia or trigger it? Cause a relapse, maybe?
Yeah, so again, I think whatever I'm going to say needs to be taken with a pinch of salt, because unfortunately, the data which gets published in the literature, including the people in here, we would always, if there is an anecdotal evidence that a patient had a vaccine and then had a drop in the blood counts, we would always want to report it. But for one patient who had that, either a drop in the blood count due to vaccination, related to vaccination, or had a normal blood count and then the blood counts went down after vaccination, there will be another 99% of patients who would have had a vaccination and safely tolerated it. So yes, there has been cases which has been reported in the literature linking vaccination with potentially decline in the blood counts with aplastic anemia, and also relapse of aplastic anemia, and also new onset. But you can count those cases with the fingers of your hand, while there are a number of other patients who would have had vaccination without having a significant impact. But I think I always advise our patients when they have vaccination to have a blood count done, not to be too complacent, but to monitor for signs of bleeding or any other signs, so that we can check the blood counts over a period of time, so we can feel reassured that there has not been a direct impact of the vaccines onto the blood counts.
Maybe can I just mention that in Germany there have been cases collected, and there has been a recommendation that after you've had immunosuppressive therapy with ATG, you should be careful after that with the vaccination. What do you think about that? Because it kind of makes patients insecure of what to do, because the recommendation for vaccination is clear.
Okay, So I can take that, and I'm sure other people will pitch in as well. So I should have mentioned this because at the early time point when the COVID infection happened, this is during the first wave. I think a group of people, some of them are here, like Regis and Antonia, and also Neil Eng, and also Professor Judith Marsh. They put in a recommendation, which is there in EBMT and also in the ASH, American Society of Hematology guidelines, where we said that to avoid vaccination during the first 6 months after ATG treatment for aplastic anemia, because the reason was not because people were worried about complications of the vaccination during that time, because we were all skeptical when you have ATG and cyclosporin at such a high doses in the first 6 months, whether patients will respond adequately or not to vaccination, which is the reason the recommendation was that don't get your vaccination during the first 6 months after ATG and cyclosporin. But that needs to be looked at over a period of time. Is it really true that they will not respond? The data which I showed you, published in Lancet Hematology from the Leeds Center, actively excluded patients who had recent ATG treatment. So from that data, we might not be able to get that evidence. But it was mainly done not because of worry about toxicity, but the worry that patients might not be able to mount a response against the vaccine.
Thank you.
I think this is a problem also for other patients receiving immunosuppressive therapy, cancer patients, but also patients receiving steroids or other immunosuppressive drugs. It is well known that during certain treatments, the response is lower, but the problem is that the decision should consider also the situation of the pandemic. I don't think that in a period where particularly during the first waves, where the strains were more aggressive compared and associated with a more severe disease compared to the Omicron, the actual strains. In that periods, I think that it was not appropriate to delay a vaccination due to the risk of a lower response. At that time, it was important to obtain any type of response after a minimum response that will be, in some cases, sufficient to avoid a severe infection. So I think that this is a particular situation, different for other type of vaccination. We know that other vaccination should be preferably performed in certain periods when the response is better. But for COVID, I think we need to follow, first of all, the outcome of the pandemic. When in a period with a high level of diffusion, I think in that period, any type of response could be useful for our patients. So I think that for this particular issue, there is not agreement with the doctors, and there is a confusion in the indication in the various centers. So I suggest to not delay vaccination, particularly during the more crucial pandemic periods.
Mm-hmm. Thank you. Carlo also raised his hand, and after that, I'd like to pick up some other questions in the chat.
Yeah, thank you. Just two short comments. First, that the same recommendation that Austin alluded to, performed by ASH and EBMT, were also performed by the European Hematology Association. In line with what Corrado said, we also can comment that the Ministry of Health in Italy gave an indication, suggestions, not strict indication, not to delay vaccination, and that we have done that also in leukemia patients, which are probably more high immunosuppressed than not in the very acute phase. Let's say that we took a lag of 1-2 months far from the very intensive treatment phase. But the point is that you should achieve at least a kind of response and try to avoid side effects that we haven't seen really very many, not even in aplastic anemia patient or in constitutional marrow failure, but also in leukemia patients. So, and back to the comment of Austin regarding the anecdotal appearance of cases after vaccination, we also witnessed some aplastic anemia cases that were chronologically following the vaccination, and they were not just a drop in the blood count, were really aplastic anemia. But of course, that does not exclude at all the fact that for 2 patients we have seen in the last 2 months, you may have so many that with the vaccination has avoided complications and even further worsening of the disease itself. So the point is that we cannot deny the phenomenon because that's part of the reality, but in a risk advantage balance, you should really carefully weigh appropriately the advantages you have with vaccination.
Yes, thanks. That's a very important point. Somebody actually wrote about a specific case where the son of a participant here had aplastic anemia and it returned. I suppose it's a relapse after 3 years being stable following ATG after his COVID booster. And she's asking if this is cause or coincidence. He's in for a BMT now and will have his COVID vaccine at 3 months after the BMT, I guess, but very scared. She's very scared.
Yeah, I think it's a very difficult balance there, is it, Pascale? And whenever it comes to individual cases, it's so difficult as well. Yeah, it's very difficult for me to say whether it's a cause or a coincidence. The only thing I might say, and I'm not moving away from the question, is the way patients respond to vaccinations post-transplantation is very different to the way patients would respond if somebody hasn't had a transplant, because it's the donor's immune system which is trying to respond, which is not the same. And as Carlo said, anecdotally in UK, we've reported even relapse of aplastic anemia even after an influenza vaccine, like a seasonal flu vaccine. Mm-hmm. There is a risk-benefit ratio as well. Yeah, would you rather have a vaccination against a seasonal flu, or would you have a bit of a flu and get over it? While we know, at least in the alpha and the variants in the COVID, there were quite a lot of a possibility of complications with COVID vaccination as well. And again, we have even seen patients who had COVID infections and then had relapse of aplastic anemia as well. So it's a balance as well. And I cannot stand here and advise you can safely have the vaccination 3 months after bone marrow transplant. It's again a question of discussion with your own team and weighing up the risk benefits as well. But the one thing is the immune system is different after a transplant versus a patient who's not had a transplant.
Yeah, thank you. Then actually someone is asking about the risk or what she can do to reduce the risk of getting COVID. As I recently had a BMT and someone in my household works in a kindergarten.
Well, it's never an easy one. I mean, I would say that the first step is obviously vaccination, even for transplanted patients. And then if you're not responding, you may need some antibodies injection to protect you if you're not a responder. And then after this, of course, you have to do all what we were doing before vaccination was available. All those things, washing hands, protecting yourself, wearing masks, avoiding all full of people together. But then there is no magic, of course, possibilities. I mean, you have to do what you can to avoid it, but you might get it anyway. So, of course, if you are have been transplanted, in, I would say, the first 2 years, of course, you can get vaccines and response, but then if possibly, you may avoid those kind of situations with little kids that are bringing many infections, and not only COVID, they can bring zoster virus that are even more dangerous for transplanted patients. But I know that it's just not possible sometimes. So we're just doing recommendation, and then of course we are accompanying patients, trying to explain, and also for the boss of our patients, to explain to them how fragile they are, even if we don't see anything anymore. We are trying to make them working at least for a temporary period of time outside some risky situation. But sometimes I know it's not possible, and it's very risky.
The only, Pascale, only additional reassuring thing, which unfortunately we did not have in the early days of pandemic, is, I don't know how it is in Europe and other countries, but obviously in NHS, in people who are non-hospitalized, and if they get a COVID and they are clinically extremely vulnerable, or in that population, they are eligible either for antibody treatment and antiviral treatment. So this is something as a learning, I couldn't have talked about it a year back. So this is something as an additional layer of protection for patients. Different healthcare authorities are bringing in these treatments which could reduce the risk of complications and further hospitalization. And also for people who are hospitalized, there are certain treatments which can be given to dampen down the process and reduce the complications.
Okay. Then there's some questions on the Omicron variant. Somebody's asking if the Omicron variant is less likely to cause hemolysis than other variants, and if there's a special kind of vaccine that you could use for Omicron.
Again, I don't think so there is enough data to say that Omicron would cause less hemolysis or more hemolysis. I'm still not very much up to date with the protection of vaccines. We all know that the newer variants, BA4, BA5, and other variants have the vaccination has got lesser efficacy compared to the Alpha and the Delta variants. But I don't know whether Dr. Corrado has got any data around it to see whether different vaccination strategies should be used, but I don't think so.
Okay. Maria, do you want to take over with the next questions?
Thanks, Pascale. So we've got a couple more questions left because we're coming to the end of the hour. So one patient is asking if they're not, if they've got PNH and they don't currently receive treatment, is the risk of having a severe hemolytic response higher than having the vaccine itself? So this could be in a country, for example, that doesn't have access to treatment.
Yes, I can take this. Actually, the risk of breakthrough hemolysis, actually of hemolysis in PNH patient after vaccination is well known. So if you are receiving an anti-complement treatment, the severity of this breakthrough hemolysis is much lower, and even the risk itself is much lower. So in a patient who is not receiving any anti-complement treatment, the risk of hemolytic crisis is higher, and but by itself, this is not a reason to start a treatment. So I think you should discuss with your doctor the reason why you are not receiving a treatment, and in my opinion, this is not a reason to not deliver a vaccination to these patients.
Thank you, Professor Rositano. So there's been a question also about any long COVID type of complications in relation to either aplastic anemia or PNH that anyone is aware of?
Well, yeah, basically what we should not forget that before being a plastic or PNH patient, you are a patient. So we could suffer as a patients from a long COVID infection, and especially in our patients that are anemic and more exposed to fatigue symptoms. So there is no specific, at least in my core of patients, there have not been specific complications from COVID in the long term, outside some immune thrombocytopenic cytopenias, so some patients who presented some severe cytopenias isolated to platelets and responding very well to immunoglobulin that we saw 2 times. In the other way, you could have some fatigue related to COVID symptoms for at least 3 to 6 months, like we observed in the general population.
Thank you, Regis. If anyone else wants to add anything, please do. There's a question about if a patient does need to go to hospital if they have COVID, should they be treated in a hematology ward by a PNH expert?
Yeah, definitely. At least they should have discussion with their primary treating physician, who is a hematologist who probably has got a PNH interest. In UK, it would be one of the 2 centers. So definitely in conjunction with the treating centers is what we would recommend for those group of patients. It might be that they don't need treatment, but at least a discussion should happen so that we can monitor. And as Dr. Corrado said, sometimes we advance the infusions of eculizumab or ravulizumab, or they are monitored on clinical trials, so we can learn more in this scenario so that we can treat appropriately.
Thank you, Dr. Austin. So we're at the end of the session. Just one more question, if I may, before everybody carries on with their evening. So what experience, if any, can be reported about the drug Evusheld in helping to prevent COVID for PNH and AA patients? I know it's not necessarily used in all countries. I don't think it's being used in the UK currently, but I think it may be being used in other parts of Europe.
So we are using it anecdotally in patients with PNH and aplastic anemia, because outside transplantation, they are responding very well to vaccines, especially with boosters like Austin was showing. For transplant patients, we are doing systematically at the very early stage in the first 3 months. When they are getting out the unit, they have their first injection, and then every 6 months until vaccination. And we are also targeting patients, about 20% of them transplanted, who did not respond to vaccination after 2 doses.
Thank you very much. Do any of the experts want to add anything to that last question?
No, I don't have any experience, but there is a question about Omicron specific vaccine. I know I did touch upon it, but I don't think so there is any yet, although because the virus adapts, so we have to adapt as well. So the currently available vaccinations are effective for the Omicron as well, but the degree of protection offered might be slightly lower. So every company is trying to tweak their vaccination as the virus evolves. The vaccine strategies evolve as well, and some of them are including two specific ones. So one against the Alpha and the Delta, and one against the Omicron. So the ability to protect patients could evolve as well, which is not dissimilar to vaccination strategies for yearly influenza vaccine, because the flu virus evolves, so does the vaccine, because no one flu vaccine is the same every year. So people change as time evolves. So there will be more modifications as we go along.
Thanks, Austin. So I would like to thank all the experts who have joined us this evening to provide really important answers to questions and updated information and data, and for all of those who have been part of collecting that data, which is really important to our communities, and we are really thankful to all of you that contribute to that for us. And thanks to all the participants who've joined us today and people who have submitted questions. And to EuroBloodNet, who have hosted this webinar. There are a series of webinars for patients that are being planned through EuroBloodNet for aplastic anemia and PNH patients. So please watch out for those. We will spread the word and look forward to seeing you at those in the future. So thank you very much, everybody.
Thank you and goodbye.
Goodbye, thank you.
Bye-bye all.